There you go. Thank you so much, everyone, for coming. And hopefully more people will come, but nonetheless, the session will be recorded, so you can watch it also later on. And I think there is also the translation in French, so that's actually handy. Today, what we're going to talk about a little bit is actually the use of DHIS2 for campaigns. I don't know if you've already seen it. We have done recently also a webinar about that. And we started mostly like at the beginning with supplementary immunization activities. And that came out of the need because after COVID, after many years and more than 50 countries that have adopted DHIS2 for EPI, and there were like new use cases. And of course, like the COVID pandemic has brought a lot of like different type of implementations. We thought that bringing in together all the type of experiences and use cases that we have found out there was very much needed, as the need like was more expressed by different countries. We started, as I said, with immunization campaigns, but there are many more campaigns out there. Like, I don't know, bet nets distribution, mass drug distribution, of course, campaigns for residual spraying. And today we're going to see a little bit of different use cases, not just necessarily immunization. And just to give you a little bit of an idea, what we put out already, it's what you see here at the bottom right of the screen. It's a short documentation on the use, the design, and the implementation of the DHIS2. So like different type of considerations that you have to keep in mind in order to put in place DHIS2 for a campaign. And of course, when we are talking about a campaign, it's not just about entering the data, but like it's about planning the pre-campaign phase. So we're talking about micro-planning, try to understand what is your structure and such, how you're going to use DHIS during the campaign. So of course, you might track your coverages, you might track like your teams, you might track your progress. And most importantly, also how to use the DHIS for the post-campaign. We all know that probably DHIS2 is not the tool that you might want to use for your coverage surveys, but nonetheless, you can still integrate this information and maintain it in order to triangulate this information later on in your national HMIS. So we will try to like cover a little bit like how these different use cases have approached the different type of campaigns. And of course, as I was mentioning, and of course, we saw it the other day as well from Scott, the presentation, how much potential there is DHIS, especially for micro-planning and mapping at the moment. We have seen different type of use, like from the org unit profile, where you can put so much information linked to your organization unit, be it your, for example, target population divided by by age groups. So it could be, for example, either whether it's a vitamin A distribution, whether it's an immunization distribution, or for example, try to map your structures, or in general, trying to catch like the catchment layers, so you can actually understand where your population is and like how it concentrates in the different areas that you're trying to target. Of course, it's really important, especially when it comes to campaign, to remember that the micro-planning that you've done can be carried with you, because right now with the Android app, you can have your micro-planning and your dashboard offline, so you can actually follow your progress as it goes. And of course, he was also mentioning the other day some upcoming features, like, for example, the printing, that is very important, but also what's very handy, especially for campaigns, it's the travel time. So you can actually plan how much time it will need you to reach the different communities, and also to better plan the kind of the resources that you need to put in place in order to reach them. Again, as we were saying, it's about considering the different phases of the implementation. So like, for example, whether you're doing offline data collection, if you want to do any kind of like checks for quality for your data, if you're doing real-time monitoring of your data, whether you're doing retrospective analysis and such. And then there can be also integrations that you might want to consider, like, for example, Rapid Pro integration. We have seen many already, and we are working even to build it even further. And of course, as I said, the evaluation, it might not be your main tool, but you can still triangulate this information and bring them in your national HMIS. Also, if you want to do a rapid convenience monitoring, and of course, trying to like use other apps that are already available within the HIS for enhanced analysis. Here we are talking about bottleneck analysis, the action tracker, to try to like make sure that you are on track when you are planning your follow-up activities to maintain the goals that you have set. And with these, like, I don't want to steal any more time because I think that we have a really good use cases today. We have 3 presentations, all covering campaigns, but in different forms. Here, the first one is going to be Babacar Ngom, who is going to show us how they used DHIS2 for mass administration of medicines. Then we will have Pramil, who will show us how the system has been used for supplementary immunization activities in Timor-Leste. And finally, Kofi, I hope everyone knows him. He works for West Africa, and he will show us a little bit like a different use cases across West and Central Africa, both for immunization, but also other type of campaigns that they have done, for example, for mosquito nets and such. So with this, I do not wish to actually steal any more time. And I would actually invite our first speaker to come over, and is going to be Babacar.
Yep. It works. Yep. Is it okay? Yeah. Am I audible? Yeah. Thank you, Victoria. Good afternoon, everybody. So my name is Babacar Ngom. I'm the digital data system lead at SIAs, and I'm based in Senegal, Dakar. So today's presentation will cover the use of the DHIS2 for mass drug administration and real-time reporting and monitoring in Nigeria. So I have 2 co-authors, Laura Senjo from UK and Christian Enwusu from Nigeria. Often what we've seen so far is MDA records are compiled at the end of the MDA campaign. And it's only at that moment that the programs are aware of any issues regarding the coverage. So at this stage, it's often too late or more challenging, if I can say it like that, to have an adequate mop-up of the campaigns. Now, this presentation will cover the efforts that we've done so far to support the digitization of the mass drug administration from the community level to up to the national level using the DHIS2. Yep, it's not working. Well, so here is the outline. So we'll put focus on the planning, the design, the implementation, and the evaluation, basically as Victoria presented, and we also present some recommendation in the scale-up plan. So you need to know that we are talking about neglected tropical disease, and it's a set of 20 disease or disease group with a single commonality, and they have an impact on impoverished communities. So MDA is a kind of a strategy that is implemented to administer drug to at-risk populations in given areas, and regardless of their disease status. And it is implemented in NTD endemic areas, as I said, such as Nigeria. So since 2019, we worked with the Ministry of Health, with the Federal Ministry of Health, through the Accelerate Trachoma Elimination Program, which aims to to support at approximately 8 countries to eliminate trachoma as a public health, as a public health risk. And during the assessment that we've done so far, there was some bottlenecks when we wanted to implement the tool. There were delay in terms of the quality of the data, and also poor documentation of the treatment numbers and the reporting rates. And also, Nigeria Federal Ministry of Health uses the DHIS2 as the HMIS for routine health programs. So in terms of planning, the first step was we worked with the M&E unit of the NTD program to identify use cases with the manual process of reporting data from distribution campaign. And right after we examined the existing data collection tool, the data flow and the indicators, but taking into consideration also the real-time approach. The other thing also was to define the user profiles and the roles and the users that will use the platform, and we also put in place a kind of long-term training plan strategy in order to make sure that the end users, such as the LGAs, the local government areas teams, and also the state team, will be able to use the platform accordingly. And initially, right after those phases, we piloted the tool into 2 states, and we've done an evaluation to understand how the tool can strengthen the quality, the accessibility, and the usage of data for programmatic action and ownership. This is actually a diagram that shows the flows and the roles during the mass drug administration, the campaign. Initially, prior to the MDA, information regarding the targets and also the drug allocation are entered into the platform. So it's done at the LGA level, those targets. And as the MDA progresses, they enter the information regarding the treatment data and also the drug allocation and the drug usage. And right after, we have a kind of a command center that is set up at the state level, where the state teams and also the the LGA teams will reside approximately 10 days in order to provide technical support regarding the data entries and also the low coverage and the numbers. And at that stage, any issues that may arise should be reported through the command center so that they can support the teams accordingly. In terms of design, we have different components that we've took into account. The first one is regarding the hierarchy. In terms of hierarchies, we set up the organization unit hierarchies, taking into account the standardization at the the standardization of the list of the communities. So information are collected at the communities level. And at that stage, we worked also with the Federal Ministry of Health in order to harmonize the process, because that process was not harmonized initially. So basically, what we propose a kind of mechanism in order to have a two-level verification at the state level and also at the LGA level before we upload the list of the communities into the system. In terms of frequency, they enter the information at the information regarding the population target at LGA level, where those information is entered annually. And for the treatment data, it's a daily reporting. For the population itself, it's provided by the state entity data manager, and he used the projection from the previous census based on the information regarding those demographic information. And for metadata, so we configured the organization unit, the program indicators, and also the data elements based on the forms that are validated or that were validated by the program. And system-wise or platform-wise, we use the the single event without registration, and also the capture module in order to enter information regarding the treatment. And in terms of the population information, they enter those data using the aggregate platform, which is the data entry. And right after, there is a data visualization aspect where we designed the dashboard using the scorecard to track and visualize the information. Some legends to at least highlight the threshold coverage using the conditional formatting and for the drug ratio allocation. So we also monitor the comments and submission in order to take into account information that will be provided for the command center that needs to be taken into account. So here is a snapshot of how the forms look like. So on the left here, we have an online forms to enter the distribution team activities, which is the treatment data, and it includes the census, the treatment information, the drug usage, the drug allocation, and also some information regarding the disability and the SIAs, which are the severe adverse events. The scorecard is also put in place in order to drill down or roll up information from the community level up to the national level, and those information can be aggregated to highlight or to display the coverage. There is also here a gauge that display the overall coverage based on the districts, which are the local government areas where the mass drug campaign took place. In terms of implementation, several benefits were highlighted. So the first one is regarding the improvement of data quality and completeness, which will allow us to at least know, for instance, to track down the errors and see if there is any issues regarding the quality of the data that was submitted. We also the platform also allows visibility on the progress of the campaign, and to easily identify issues with reporting and coverage, allowing for course corrective action. And the last point that I wanted to mention is, when we put in place this platform, it allows also to know, for instance, if there is any data manipulation, which can help us also to flag the issues and put more investigation regarding those data manipulation. Among the challenges, there were some disparity between treatment reports on the DHIS2 and the state Excel treatment. As I said in the beginning, so the government or the program itself, they were using an Excel spreadsheet in order to aggregate or to collate the reports. And when we were doing the comparison or the evaluation, we saw that those information that they reported on the Excel sheet were different from the one that they reported on the DHIS2, and that was one challenge that we are trying to solve. And in terms of the reporting, also there was some delay on the platform due to internal review process, and also some poor internet services such as the connectivity. And lastly, as I said, since before each mass drug administration campaign, we need to have the list of the communities. Information are collected at the community level. Sometimes there might have some delays in the submission of that list to be uploaded into the system. Thanks to the Task Force for Global Health, we were able to evaluate the tool. So a study was conducted in order to see the usefulness of the tool in terms of the during the mass drug administration campaign. So we were focused on two aspects. The first one was the coverage evaluation survey, which is a kind of survey that helps to validate the reported coverage estimate. And what we've found, what we've seen so far was that there were a disparity between the coverage reported and the coverage surveyed when we've done the coverage evaluation survey. And unlikely they might have some issues with the denominator population. That's why it was one of the findings that we've seen so far when we've done the coverage evaluation survey. The other one is regarding the government ownership. And in terms of government ownership, we took in place 2 to 3 dimensions: data use, data quality, and based on those information, we found that the platform helps the team and also the country to improve those aspects regarding the government ownership. In terms of recommendation, there are several of them. The first one is regarding the LGA workload. As I said, it's a kind of duplicate entry, because in some LGAs, they are using the Excel sheet, and there is also the DHIS2. So the program, we are working with the program and the country itself in order to replace that spreadsheet used at the LGA level, so that the system can be used properly. The other thing also that I wanted to mention is regarding the community listing. The context in Nigeria is quite sometimes challenging because of the number of communities that we have within the country. So it will be good to engage early, as soon as possible, with the LGAs and also the states, in order to have the community lists that need to be uploaded before the MDA campaign. And the other one that I wanted to mention is regarding the connectivity. Definitely, since the tool, I mean, if you want to use the DHIS tool, you need to have internet connection, and the infrastructures that needed to be taken into account prior to rollout. In terms of system-wise, so since we are also collecting information regarding the drug usage, so a separate drug tracking system need to be put in place so that we can track down the drug availability at each level, and then also the logistic team can give more insight, can have more insight on that system. And the last one is enhancement into this, I mean, regarding the system by adding some kind of validation criteria or validation rule based on the maximum and the minimum range for certain indicators. For the scale-up plan, so you have here on your right a map that shows where the DHIS tool was rolled out, and so far we implemented in 13 states, with the exception to scale it up to all the 36 states and the Federal Capital Territory of Nigeria. We haven't integrated the morbidity information, such as, for instance, if you take lymphatic fluorescence, those hydrocele and lymphedema cases, morbidity cases. So we want to integrate those information into the system. The other one is regarding the historical data, so that we can at least have an overview of the past treatment that took place within the country, and that will help also the ministry to improve the quality of the service. And lastly, increasing also the coordination with NTD program and also the directorate that manage the national system by having kind of interoperability, where those data that we collect during the MDA campaign will be integrated into the HMIS. That was it for me. Thank you so much. Thanks for attending. Yeah.
Thank you so much, Babakar. It was fantastic.
Thanks.
And it's always nice to see new use cases, actually. We are having now Pramil, who unfortunately couldn't join us in person. It's a pity, couldn't get the visa on time, but nonetheless, he has a super interesting implementation presentation for immunization activities and other stuff. And I see him that is online. So hold on a second. Yes, can you share your screen, Pramil, please? Super. I bring him here. Voila. And then I go this one, right? There's a multi-step approach here. Okay, can you give it a try to talk to see if everyone can hear you?
Hi, Vito.
Fantastic. Okay, then I leave you the floor. Thank you so much.
Can see the screen, right?
Yes, we can see. Thank you.
Right. Okay. Good morning, good afternoon, good evening, everyone. So I'm Pramil Lianage, consultant for HMIS. So apologies for not being able to be there physically, but I'll be sharing the experience of Timor-Leste on using DHIS2 for this supplementary immunization campaign, which happened this year. So this is an outline of my presentation. So I'll be briefly showing what Timor-Leste Health Information System is, which is TLHIS, then what is happening in the immunization related to TLHIS, and with what Vito shared the outline of pre-campaign, during campaign, and post-campaign, how we did use the DHIS2 to manage this campaign, and what is our follow-up plan. So just a little bit about Timor-Leste for those who are not very familiar with the country. So it's a very young country. So it's the first new sovereign state of the 21st century, where it was declared a sovereign state in 2002. And so the country is still 20 years old, and it's about 14,000 square kilometers in size, and population is just over 1.3 million, according to the recent census. And in the structure of administration, there's 14 municipalities, one national hospital, which is called the HNGV, then 5 referral hospitals, 72 community health centers, and 350 health posts. So TLHIS, which is Timor-Leste Health Information System, which is DHIS2 based, was implemented and initiated in 2014. So this is the snapshot of the journey of the TLHIS. So as I mentioned, it was initiated in 2014, then initially in 5 districts, then 3 districts added, then 5 districts more added. So likewise, it expanded till 2020, and then after 2020, it had a major leap because there were so many developments, especially due to COVID, related to COVID-19 immunization tracking, and also other immunizations, then version upgrading and adding of indicators. So what is happening in the immunization in Timor-Leste, in this Timor-Leste health information system? So we have monthly aggregate data for EPI reporting from health facilities. So each health facility will send a monthly aggregate into the system. And also, in addition to that, we have COVID-19 daily reporting, the number of doses given for COVID-19 vaccinations from each COVID-19 vaccination post. So this has been happening for the past 2 or 3 years, and it's still continuing. So daily we have the COVID-19 vaccination data, and this data entry is done at community health center levels for all the health facilities, mainly because due to these communication challenges, we have some internet issues in the smaller health posts and other health facilities. So CHCs, the community health centers, are the main point of data capturing in Timor-Leste into the system. So apart from that, this year we have done this supplementary immunization campaign, which I'm going to talk now, and it was for 5 drugs, like 3 vaccines and 2 other drugs. It was for PV, PCV, measles, and also vitamin A and albendazole. And then we followed it up with this immunization coverage survey in 2023, March to April, for EPI in both SIA. So this is an outline of how we use the system for this supplementary immunization campaign. So we had pre-campaign planning, where we did the operation plan designing, testing, and training. And then during the campaign, how we use the data DHIS2 for data capturing, then validation and improving data quality, then how we send daily updates and conduct a real-time monitoring. And post-campaign also, we used a lot using the TLHIS. One is the rapid convenience assessment, then the data audit and a coverage survey, and which made this data triangulation possible. So moving on to pre-campaign planning. So in the operational plan, we use TLHIS to get this routine EPI coverage for this to do the initial needs identification and resource allocation. So from this chart, you can see the red lines where we needed to protect these children, especially from 1 to 5 years, with these for measles and rubella. And then also enumeration was done also using these family registers and house-to-house visits. This family register also came from an electronic version from another software. And then for setting targets for each municipality, how many children should be vaccinated, how many children should be administered the drug, because we had a 95% minimum target. And using the enumeration and the population estimates from the TLHIs, we were able to set separate targets for each and every municipality, and then also to plan where the vaccination posts are conducted. Using the facility mapping, we had all the health posts mapped in the system, so it was easy to plan the vaccine posts. And also we had integration with the COVID-19 vaccination. So the SIA was integrated with the COVID-19. So in vaccine post, both the SIA components and the COVID-19 vaccine was given, and also for planning of this infrastructure, the equipment and the connectivity. This is the design, how we plan the design, especially the data flow, how the data was fed into the system and how it was aggregated and analyzed. For example, the vaccination post, we had a daily return coming from the vaccination post, and it was sent to the community health centers or the closest health post, or sometimes the private clinics, the hospitals and HNGV, the National Hospital, they also conducted vaccination posts. And these were aggregated at these places and sent to the CHCs for capturing. So capturing into the system. So from above the CHCs, it was totally paperless, and it was managed through the DHIs too. So how to place these vaccination posts and the metadata for data collection, that is the data sets, then outputs for analytics and user management. So everything was done during this design phase. And then we also did the testing. We have a test server, so tested with data entry and analytic performances, and also how the users accepted the system for this campaign. And then further on pre-campaign, we had this training and readiness. So we did a national TOT, and also then subnational level training, and also then we prepared these guides, one for a campaign guide and one for the system guide. So we had one pages for data entry and also one pager for data validation, both in English and Tetum version, which is the local language, and also conducted a readiness assessment checklist. So during the campaign, so this is what we did during the campaign. As I mentioned, it was a hybrid system. We had paper-based at the vaccination post, and then aggregated and entered into the system daily. So paper-based and electronic hybrid reporting was used, and daily aggregate data entry was entered at the CHCs. And these contained doses administered for each product, all 5 products, with the sex disaggregation, and then also the AEFI and the reactions for the vaccines and the drugs. Then stock information, how many received, how many given, how many discarded, and how many returned, those types of information for all the drugs. These were entered daily, and it was advised to enter it before 10 AM next day to have the completeness. So timeliness was set to 1 day, and completeness we allowed 5 days, if sometimes it was the weekend. So that was how we conduct the campaign, and also how we ensured data quality. So we ensured the validity, consistency, and accuracy using these inbuilt validation rules. For example, if you think of oral polio vaccine, which is given to all children, and other vaccines were given to only certain age groups. So there had to be, the oral polio had to be more than other vaccines. So those kinds of validations we included in the system that was validated during the data entry, so that warnings were given and errors were minimized. Then we used outlier detection and trend analysis also for improving data quality. And then we generated daily updates. So all these infographics were sent daily. So next day after 10 AM, with the data in the system, we send daily updates with coverage, reporting rates, and the cumulative numbers with targets and the data tables. All these were sent to all the healthcare workers using WhatsApp and email, and it was monitored daily using these. And apart from that, the administrator also use this dashboard, special dashboard for SIE campaign, where we had all the charts, graphs, and maps. And apart from that, they also had used in the data visualizer and the maps app, they created tables, charts, maps as they wanted, and used it for analysis. Then moving on to post-campaign, so we conducted this rapid convenience assessments. So this was also like a hybrid one. Some had filled it in paper in the fields and some had it in the system. So all those who had it in paper then came to the centers and entered it into the system using DHIS2 Events app. We were planning to use the mobile data capturing, but due to devices issues, then we couldn't complete that, but it was totally then entered into the system finally. Then for this post-campaign evaluation, then we also had a separate data analysis component on RCA, how many how many children were vaccinated, what is the coverage in this assessment. So that kind of snapshot view was able through the system. Then we also, the HMIS Department of Ministry of Health, they also conducted an evaluation, a data audit to check the data completeness and the accuracy of both the SIE and also the EPI. So we checked for these transfer errors from paper to other paper, and then aggregation errors in the papers, and then data entry errors, validation errors. So all these errors were checked by the team visiting each and every municipality. They did a data audit both for SIE and EPI. And following the completion of campaign, we had this EPI coverage survey. So that was the first time we had a total digital technology-based survey for coverage in Timor-Leste. So there we used individual event module in DHIS2, and we had tablets. And using the mobile app, DHIS2 mobile app, we conducted the survey, and we were supported by the Department of Statistics, who also had some experience doing the census. So they also supported us. And in this survey, we captured all the locations and then EPI and SIE coverage both. And there were separate dashboards for the supervisors and also for the managers to check daily how many areas were covered, how many clusters were covered. So that was daily monitored by the supervisors. So in follow-up, we were able to get 100% reporting into the system. So all about 6 weeks we conducted the campaign. So everyday reports were completed by the end of the campaign, and almost all districts had good timely reporting also. And then using this monitoring system, we were able to achieve the national targets, which was 95% coverage for all the products. So now we are awaiting the final results of this immunization survey. And then we have 3 data sources for this immunization, and we can do a good triangulation of data to check the coverages and where assess further interventions and plan for the further interventions. So these are some pictures from the users who are from the peripheries, the CHCs, supported by the supervisors. We had immunization consultants also supporting them, and they were quite happy with the system and what they have achieved through the system. So thank you very much. Obrigado, Barak. That is in Tetum language, the local language. And thank you very much for listening about the success story in Timor-Leste for SIA campaigns.
And thank you so much. They looked indeed pretty happy when they were entering it. I don't know if they were posing, but they looked happy enough. Thank you so much for the use case. It was fantastic to hear. Also, especially for the evaluation. Actually, that's pretty interesting. I haven't seen a lot of use cases for the evaluation, so I think that's pretty useful also for other users out there to see that it's possible to do also directly in the HIS. So thank you so much, Pramil. We have our last presenters, and it's Coffee, who is going to show us a little bit about hold on a second. He's going to show us about the work that West Central Africa has done across the region, and he is going to give us a little bit more information about the campaigns they have supported. So, to you, Kofi.
Thank you, Victor. And this is a presentation that was put together with the team from East West Central Africa. I hope you can hear me. Okay, so you have the team members there, and we're going to share with you some experiences regarding immunization campaign in Congo, but also some highlights from the Bennett campaign that we did in Guinea and then Niger. Oops, not coming on. Okay. Is it moving? Okay. So there are the outlines. In terms of background regarding the campaign immunization that we had in the Congo Brazzaville, not DRC. So in 2020, the country was facing a large-scale measles immunization epidemic, and it was hitting 9 departments out of 12, and with a health deadly toll for children. Then you should know that in Congo, measles is rampant in the country in epidemic and endemic mode. But over the previous years, we have seen an increase in outbreaks across the country. At the same time, the country was facing a resurgence in yellow fever, especially in the Pointe-Noire department. So it was decided to have an immunization response, and that was decided to be done in the DHIS2, which was the first time they used DHIS2 for this kind of intervention, and that was under recommendation from Gavi. So this is a snapshot of the form that you use, and we have configured in the DHIS2 two forms, one for the synthesis, daily synthesis on not mumps, but measles, and another one for the yellow fever. In terms of planning, we had used an aggregate approach, and we have matched that with the national deployment of DHIS2 at that moment, because the DHIS2 was not deployed at the facility level that time. So data typing was happening at the district level, but they were typing data by health areas, which is a new data layer. Using laptop, we have done testing, training, and macro planning as well. So regarding the design, we have a metadata dictionary. We have configured a set of data element indicators and imported the users from API spreadsheet. In terms of hierarchy, I was saying that we have to create a new layer, which is health area, a set of health facility, which was not there in the system before the intervention. So we were not collecting data per sex. This is something that was very interesting, because it has been now correctly documented that there is no discrimination in terms of sex. And this was a very important decision that was taken. Don't collect data you don't need, and then you don't know what to do with. And we were collecting data on the stocks and AFI as well. We designed the dashboard, and we have, for data validation purposes, configured some mailbox so that the monitoring team can monitor in real time the validation rule violations. We use usual training materials like user guide, and also what you call the testing in the field and so on. So here is a snapshot of what we designed in terms of data collection for the measles, and then something like this as well for the yellow fever. And then this is a snap on the validation rule violation messages that the team was receiving whenever the rules were violated. So in terms of running the system, we have some challenges. It's the same as the one that colleagues had presented some minutes ago. It's about the internet, it's about the agenda of the Ministry of Health, very heavy agenda, we have to adjust with it. And also there was a competition between data, routine data typing and immunization data typing, because it was the same people that was in charge for these tasks. The real-time monitoring was a success because the team was sitting at the API program, was able to have the data dashboard for both performance and also for data quality. This is a snapshot of what was ongoing during you can have the map, the figures, and so on. The same for measles and rubella dashboard. So this one, we achieved 93% of coverage for yellow fever, but you can see that we have achieved over 100% for the rubella. The API program claimed that it was an underestimation, but currently they are under an evaluation to check the denominator. This was because of this DHIS2 that had triggered another question that they are trying to answer for their data quality. We have not included the rapid convenience assessment, and the integration was done with the HMIS since the beginning. This was the impact of this campaign we did. The data was available, the report was available in 2 weeks, which was not the usual, because they used to have several months before data can be available. And we got a call from the API director saying that I'm more than satisfied with the way data was managed through DHIS2 for this campaign. I want all routine API to digitize in DHIS2. What we did, because the configuration work was done, TOT carried, and then we have ended parallel reporting in Congo Brazzaville now. The second tour for yellow fever has also been conducted in DHIS2, and then OPV was configured in May for an upcoming campaign in June. And one of the API data manager was saying that he was very impressed, and he even went further, saying that he's feeling a certain seniority after he has used DHIS2 for this campaign, and he's confident that they'll do more later on. Let me bring you to Niger for a quick snapshot on what we did there. That was some screens. There we have a BedNet campaign that we conducted on the pilot mode in 6 districts over 72. That was an increase because in the previous campaign we did 4 districts. So we use 1 tracker and 3 aggregates. We have a usual hierarchy and put some dashboard there. The challenge we faced was almost the same. We are having some difficulties in terms of Android use, despite the fact that we have a smartphone that were used. This one was a very simple one. And the one that we were challenged with was the one we did these are some snapshots of what we did in Niger. But in Guinea, we have a different type of challenges. We conducted this BedNet campaign country-wise, and they want a very huge pilot. We need to run a 3-day preparatory workshop for that pilot. Hosting was a challenge. I will come back to that later. They want a full system with 1 tracker, 3 aggregates, and they have segmented the country into 2 zones. And after we have created the normal hierarchy, they wanted us to create 2 new layers. One for the sites, so we have to create 2,500 sites for distribution, but they want an enumeration to be conducted on a village basis. So we have to design over, I can say, 20,000 villages to conduct that enumeration. Android capture was also a problem because we used the Android capture for the demo. But after the demo, they say that they don't want it anymore. They want a custom app. So we have to design it, but the resources were limited, the time was limited. We don't have the time to properly train the people. We generate 3 main dashboards, but during the running, they want more dashboard. So we have to create a lot of dashboard again. And the user interface, we need to enroll the household, and they want us to count every single person in the household up to 15%. So this creates a lot of challenges, including the fact that we have to capture stock data using batch numbers included in the system. So this is a snap of what we used in Guinea. You have some data entry form. You can see the 6 system that we deployed for that campaign, and some idea of what we were capturing as data. This is the Android version. And during the running, we have some challenges with the server. They insisted to have a physical server that was virtualized, but that server was saturated quickly. We have to purchase another server. By the way, they haven't paid us yet. And then that one crashed again. And then by the end of the campaign, they want us to move all the database to the country national data center because of some sovereignty policy. And we have to run several versions of the app during the campaign. The MDM that was purchased, they called it MWatch, that was used by SIAs, doesn't work well. When we change the version, it doesn't update it across all the devices, and then you have to manually update it and then take the data and put it in. It was very challenging. But something was very instrumental in this campaign is the real-time monitoring team made of ITs and statisticians and MNE from all the ministry sitting at the national and at the regional level. They were very reactive, and that helped us overcome the challenges that we are having. That's why all these campaigns were successful. In Niger, they want to continue with DHIS2, and they want more. They want to use stock management, and they want to use DHIS2 for the supervision during the campaign. In Guinea, a statement from the National Malaria Program coordinator, he was saying that DHIS use for LN campaign was successful, and due to his consistent support, challenges were overcome despite some data discrepancies. We want DHIS2 for the next campaign. We want a resident expert for 3 months, and they have budgeted that in their current budget so that we can go and enjoy some time there. And then we will score even better for the next campaigns. In Congo, we have a huge success because data completeness and time is over there, and it paved the way for the other campaigns, as I was saying. That have some enablers. The new API generator, which is very high demanding, we need those kind of people sitting on the top of the programs. And a good recommendation from Gary. I don't know what kind of donors are there, but I would like to plea for you to help us so that we can give some very nice recommendations at this one that we had. It worked also as an attractor for the other countries to come in, because in DRC, we were able to conduct recently Ebola campaign using DHIS2. We have secured funding to conduct WHO funded campaign in Togo. And then we just have a request from Sierra Leone for a routine immunization acceleration campaign. So we think that these experiences has been very successful despite the challenges, and we are looking to do more. That's all from me, and thank you for your attention.